Okay, retrocalcaneal exostosis, as we can see that there is something called a Haglund's, which would be, if my finger would be on this side, that wasn't causing him the pain, but that's considered a Haglund's deformity, the enlargement at the back part and the upper part of the heel. And then there's that protrusion, which is an exostosis, which is a spur. And they call it retro because it's in the rear, calcaneal because it's the heel bone, and exostosis is a spur. So retrocalcaneal exostosis. As we can see, the radiographs clearly show the Achilles tendon, the little bit of whitish band, as we can see. So to some extent, radiology today, digital radiology, is tremendously improved in comparison to previous films and studies. It's very, very descriptive and involved in regards to tears that to some extent is very beneficial, especially along ligaments of the ankle and tendon structures. But obviously MRI is still much, much preferable. In this situation, we can see this protrusion, which is fairly large. He does have a history of gout. He does have the inflammation around. But nonetheless, that was causing tremendous pain, and the cause is obviously due to equinus, which is a tightness of the Achilles and a foot type. So that was before surgery. So upon doing surgery, there are multiple incisions that can be done that are described in the literature, and this is after surgery. As we can see, the Achilles was reflected back, and you can see a little bit of whitish around that area. We have to use hand instrumentation. Preferably, if there was a reciprocator, pneumatic would be phenomenal. Otherwise, we cannot use rounded burrs. Those create holes rather than, and also the area of incision is too small. The vacuum creates damage to the structures such as the nerves and the tendon in the area. So it's more harmful to use a rounded burr or a pineapple burr or whatever burr you choose, such as a cyclone. So it's preferable to use a reciprocator. That is preferable if your facility does have that. So to avoid the hand instrumentation, because it does take time. It does take a lot of rasping on your behalf, the surgeon that is, to kind of grind it down. You can use osteotomes. In this situation, we did use to remove the chunk of spur, and also then followed by hand instrumentation. It's a small incision. I like to go right in the center part, slightly outer part of the heel, and it's usually about 1 inch long. And then you reflect the tendon and reinsert the tendon back in with anchors. I use absorbable anchors made by Arthrex. They come in variations of girth and length. They're absorbable, as I stated. The one we used on him was 10 millimeters, and it has 4 threads that come out of it to anchor the tendon back in, the tendon of the Achilles, to anchor it back down into the cancellous bone that is exposed. And cortical bone usually covers within 4 weeks and becomes fairly well. The thing about this is we need to stretch the foot with a cast and gradually get him into motion, into physical therapy fairly quick. Otherwise, this is a retrocalcaneal exostectomy, which is a removal of a spur on the back of the heel and reattachment of the Achilles using an Arthrex, A-R-T-H-R-E-X, Arthrex absorbable anchor, and has 4 threads to anchor to realign and reattach the tendon. So that's basically it in a nutshell on the foot. If we can, it's, as we can see, the cut is fairly small. What I usually do is a little bit of a definition of the heel bone, and it's very small centrally. That's basically it. Minimal swelling within 8 days after surgery. Thank you. Bye-bye.